All right, everybody, welcome to episode 5. What I've got with me today is an old colleague of mine that I actually haven't seen in years, Dr. Russo. We met back in residency probably like 9 or 10 or something years ago. But it's really good to see him, man. You've been up to a lot of different stuff, I guess, at this point, huh?
Oh yeah, 10 years, a lot of different stuff happens, both in professional life and your personal life. It's kind of crazy.
Gotcha. Well, look, so let's start off with a little bit of an intro. Tell me, like, where you from? You're from the New Orleans area, is that correct?
Sure, yeah. So I'm from Kenner, Louisiana. I like to claim it instead of claiming New Orleans, but I am a New Orleans guy. Went to LSU and didn't finish college. Went straight to medical school at LSU. And then, LSU residency where we met for orthopedics. And then I finished up in Houston doing a fellowship in sports.
Sports, huh? Excellent. And where are you located right now?
So now I'm at New Orleans East Hospital, one of the few orthopedists out here serving this great community. And it's been great.
Awesome. Well, I wanted to talk to you here today because of an article that you published, I guess it was back in 2016, on gunshot wounds. And I thought it was a really interesting article that goes into really kind of the cost involved with gunshot wounds, not just like financial cost, but like societal cost, what it means to take care of these patients and things like that in residency. What made you decide to pick this topic?
Right. So as you know, our lives in residency were very intense training, and most of the things we would get were gunshot wounds. I mean, if you read the article, 60% of these gunshot wounds need orthopedic care. It was at least a quarter of the patients in the hospital for orthopedics every single day. So you start wondering, is there more? You talk to your colleagues from different states, different cities, and they're not seeing that level of gunshot violence. They're not seeing that level of trauma. And so you start wondering about your education and what you've learned. You start wondering what the toll it has on your city, your state, your medical system. And so doing this study kind of helped me answer these questions, which was really interesting.
Yeah. So for those of you wondering, so I actually just pulled up the title of the article here. So the title of the article is "The Economic and Educational Impact of Firearm-Related Injury on an Urban Trauma Center." And so one of the big numbers that I saw in this article was over the time. So this was like a 7-year time frame, I think, right?
Correct. Tried to make it close to our time at LSU.
Okay, interesting.
Yeah.
And so 3,617 gunshot victims in this article.
Yeah. It's a lot. It's a staggering number. And, those are the ones that would come to the trauma center with a gunshot that we would be all treating together. And it's a staggering number, but it's a real number.
Right. So over 3,000 gunshot wounds. And what I found interesting was when I asked you to do this and I was driving over to do the talk, I was, Googling gunshot murder rates, things like that. And it seems like New Orleans is back at number 1, I think. I don't know have you come across anything like that?
Yeah. Per capita, because I feel like we lose a little bit of our population rather than gain. Yeah. And then, the murder rate kind of went back up post-COVID. Mm-hmm. So I think we're right on the map. And it really depends on the statistics, whether we're winning, St. Louis is winning, or some of these other cities. But Chicago's population is so big that even though they have a lot more murders and gunshots, the large population kind of drowns out that per capita number.
Yeah. So New Orleans, if not number 1, right up there. And the other thing that I noticed was that the rate of adolescent gunshot wounds or even pediatric gunshot wounds was like incredibly high as well. Really kind of like a shocking number.
Right. Looking at the study, we have people from 0 being an infant to 99 years old that were
I saw that
part of the gunshot violence. So there's really not an age limit. It's pretty staggering. And even just this past weekend, there was shootings where a 2 or 3-year-old got killed.
I saw that. I got a WWL update on my phone, and I saw that, and I couldn't believe it. And it seems like all the way, like leading up until this interview, it was like every day I was getting WWL updates.
Yeah, it's weird. These trending, it just goes in the wrong direction. It seems like it's getting better, and it seems like it's getting worse. But when you average it out, it's the same.
Yeah, it really hit me. So I'm driving across the lake to come see you, And it's occurring to me that I'm driving to the part of New Orleans where there's probably the most gun violence, and we're in the city with the most gun violence in the nation to do the interview on gun violence. You know what I mean? So pretty unfortunate, but kind of a fitting location for the talk, I think.
Right, and that goes back to why we did this study, because we are living it. This is it. It's not like this happens every other day. It's something to think about. Like, you're forced to think about it every day because it's coming to your ER, it's coming to your clinic every single day.
Right. So let's go over this age range again. So you had victims in your study that were not even a year old, right?
Right.
So less than a year old, all the way up to 90 years old.
Right. So
incredible.
Obviously, besides the psychological toll and the horribleness of it, you obviously going to treat an infant very different than a 90-year-old who gets gunshot. And gunshot treatment in itself is complicated more so than just blunt force trauma.
Yeah, I found another article preparing for this related to your article published more recently, and they only looked at adolescents 0 to 18 years of age, and they I think from 2018 to 2021 there were, from age 0 to 10 years old and less, there were 104 kids shot during that period of time.
Yeah.
Unbelievable. And under the age of 18, high school and younger, there was 1,129 gunshot wound victims in this city.
Yeah, I mean, it's amazing. I don't think people understand. You get dumbed down to it. You hear it on the news every day. You start getting like lost in those numbers. It just becomes part of the news, and it's it's sad.
You get the update on your phone.
Yeah.
It beeps. You look, www. You read gunshot wound. You just flip it off.
Yeah.
Because you're desensitized to it.
Exactly. I think us more so because we've seen it in person all day, every day, training, that it's just like, yep, another one.
And over the course of the study, there was a 43% increase in gunshot wounds in this study that was published. It was almost like your study finished and then this study started. You know what I mean? And in the duration of this most recent study, a 43% increase in gun violence in New Orleans during that period of time.
Right. And after we left residency, LSU picked up, basically did our same study and put it out another 3 years, and the trends just continue. The same money trends, the same volume trends. So nothing's really changing.
Yeah. And I guess we can get into like, what can be done, to change. It almost seems insurmountable, honestly.
Yeah, and I mean, it's, you'd have to get all kinds of people, and depending on how you feel about certain things, everybody thinks they have the right idea.
Right.
But honestly, that means there's probably no real solution.
Yeah. So let's go back to your study actually for a second. So the other staggering numbers that I came across was the amount that was actually the cost of dealing with the gunshot wounds in your study. So there was 3,600 gunshot wounds, give or take, and the actual total cost was about $70 million.
Right. So yeah, we took hospital charges, which obviously are always higher than cost, but the actual cost, the actual money that was spent on the victims over this time was about $79 million.
Gotcha. And so that was the actual cost. How much did the hospital receive in reimbursement to take care of these patients?
The hospital only got a fraction of that at around $31 million. So that means the city, the state, the taxpayers are taking that $48 million loss, and they have to bear the brunt of that. Mm-hmm. And that's a lot of money that could go to schools, education, teacher salaries. I mean, you name it, everybody's got a project that's near and dear to their heart. That money's not going to that. It's just going to taking care of gun violent victims.
Yeah, and the other striking feature is this is the cost at time zero. Like, they come into the hospital, this is the cost it takes to get them out of the emergency room, treated, and out of the hospital. After that, who knows how much, what is the consequence of dealing with this type of injury?
Right. We were talking before, I'm still seeing patients since I'm still in the area from residency. So 10 years later, that person that got shot in the femur, now they have arthritis. Now they need a total knee replacement. Mm-hmm. Some people get shot in the brain. Like, that's a lifelong, medical necessity. Several other things. You can get infections that linger. You can just get scar tissue. I mean, these things linger on and on. Those costs just continue throughout their life. And like we talked about with the ages, a lot of these people are adolescent. Now they're in their 30s, their 40s. I mean, they're starting to hurt from the residual effects of the gunshot wounds. So that money spend and that human toll doesn't end at time zero. It just goes and goes.
Yeah, I think using the word human toll really kind of strikes home to me, because in my practice, I work at a big public hospital, and we get a lot of gun violence still, and we see people who come in with the residual effects of this, and you see what their quality of life is, and it's not good a lot of times. Post-traumatic arthritis to the joint, or it seems like the paraplegics who get shot in the spine, that is just a very unfortunate situation. You know, they're wheelchair bound. They can't take care of themselves. They can't live fulfilling lives. You know, it kind of hurts to see people like that, you know?
Right.
You know, they did, you know, something, whatever happened when they were a teenager, and now they're a 50-year-old person still dealing with these effects.
Right. A lot of even those that have like gone to jail per se. Now they're getting out of jail and they're coming to see us, and they've had gunshot wounds which weren't treated very well. Now they have all kinds of complications: orthopedic, neurological, vascular, and you know, you never escape it.
Yeah, that's true. And not just taking care of the gunshot victims, but also one thing I noticed a lot going to our personal residency experience was how it also affects other members in the community. And so in your article, I actually copied this down. So dealing with patients, let's say underinsured, perhaps patients who can't receive care elsewhere, we have to still take care. We still had to take care of those gunshot victims when they came to the hospital. Like, it had to be dealt with. But then somebody might be on the books for like a total knee or a rotator cuff repair, and then and those patients would get canceled, often after being on a wait list for months. They would get canceled because of somebody or a group of people coming with gunshot wounds. And so to accommodate the surgical cases due to gunshot violence, elective and subacute orthopedic cases that serve the needs of the population are routinely canceled. I distinctly remember dealing with that.
Yeah.
And you feel bad. You're the one, like...
Right. It's a nice 60-year-old lady who's
Right.
been dying for a total knee. She can't walk. She's been on a walker or a cane, and it's her time has finally come up. She's made all these arrangements, and then she gets bumped by a gunshot, and then she gets put to the back of the line. And that was a routine event in our lives, and you feel horrible for the patients. It affects us, even though it's less intense. It affects our education, because you need to learn about how to do total joints. You need to learn how to do sports cases. You need to learn how to do fractures. And we were just inundated with the trauma aspect. And so it was sad for them. It was sad for us. And that's, you know, the lost education component on top of that sad human toll portion of it.
Yeah, yeah. Do you still deal with a lot of... You mentioned earlier you have some people that come in through. Do you still deal with a lot of acute gunshot wounds and injuries like that?
I don't deal with as many. Most of them go to UMC. The trauma center, you know, is excellent. So the criteria, let's say if they're shot above the elbow or shot above the knee, that immediately goes to the trauma center, because they have all the pieces and parts to take care of that. They got the vascular surgeon, they got they got the neurosurgeons, they got the blood bank on call. Whereas smaller community hospitals just don't have that set up every day.
Right.
But, you know, you still get people that are shot close by, and they get brought in by private vehicle, and you have to be able to treat it acutely.
Yeah. So, take me, you mentioned a little bit about your personal residency experience. Kind of take me through what it was like dealing with, okay, say you're like the intern or the second you're on call, your pager goes off, it's another gunshot wound. I'm sure you remember some of those experiences pretty well. Like, take me through, like, from a start to, like, they get surgery kind of experience dealing with this type of injury.
Well, I remember, you know, we start on July 1. So, of course, it's like the first weekend, July 4th weekend. We had 16 gunshot victims in one night that lived, that were going to be on our census. And what I remember most is the team approach. When, you know, usually there's multiple gunshots. You've got general surgery working. You've got us. You've got vascular. You've got all the nurses, blood bank, everybody kind of coalescing to, you know, kind of dance around this patient and get everything together. And I mean, the complexity of it was insane. But a lot of these people are alive and doing well because of that. And so I remember our first week being a resident was, death by fire.
Yeah, yeah. I remember that too. The I have like more of this visceral experience remembering things. I just remember being down in like the trauma bays, and then you just have this person just shot all over the place, and I just remember just the blood and the smell of that. I don't know why that stands out. I mean, well, obviously I know why that stands out to me, but that's one of the big memories that I have.
Well, I remember before the hours rules, and you'd be tired walking
Yeah,
outside just so you can like see the sun or just walk outside, and they would
yeah.
have the spine boards that the ambulances carry
Oh my gosh,
littered with
yes.
blood, sitting outside the ER, like I guess waiting to get hosed down or whatever. And I remember always
Yeah.
walking outside and just seeing that, and it's like you just like step on blood or you step on like
Mm-hmm.
bandages that were bloodied, and it's just like this is like a war zone.
Yeah, I always wonder what the EMS people do with that. Do they drop their bloody spine board off at the ER bay and then
I
grab the cleanest one and put it in the back of their
I,
ambulance and
I
go? I don't.
I never knew how that process worked, but I remember
I
that
do remember that
walking up the
too.
ramp to go to work, and that's what you'd
It's
smell and
like a war.
see. And
Like, yeah,
well, I don't know if you
maybe.
remember they sent some of the Navy SEALs to work with us,
Oh,
and
really?
like maybe it was when I was second year, and they would hang out with ortho or general surgery because
Hmm.
it was guaranteed they were going to see some gunshot wounds, and for their own like kind of medic,
Oh, I see. Interesting. Yeah, I don't remember any. I don't
they
remember.
would
Yeah.
they came and they spent some time with us, and they would just hang out and see what we see and learn, and they'd spend like a week or two and go back to wherever they,
Oh
they go
gosh,
from.
man. I never. That's crazy. I didn't know that we had that. Do you have any like any consults or gunshot wound traumas that just really stand out to you?
The rifle injuries, particular. I
Yeah.
mean, you don't know if it's an AK-47, but at the time that was like a big gun. Post
Mm-hmm.
Katrina, like some for whatever reason, it seems like people had AK-47s,
Right.
and the damage they inflict at 20 to 30 feet away was insane. I remember the forearm injuries specifically and the thigh injuries. It looked like somebody had just thrown a grenade at them,
Yeah.
just blasted, like bits of bone, nerve, artery, you know, just impossible to restore in a normal pattern. And those,
I guess a lot of them just sort of like run together. You know what I mean? It's just in particular the high velocity. So okay, real quick. So tell me the different types of like gunshot. So this kind of runs into that a little bit. So the different
sure.
types of
So yeah,
gunshot wounds.
if you haven't trained with us, maybe this isn't as common, but
Mm-hmm.
you have the low velocity, you have the handguns, you have it's a slower bullet, it's a smaller bullet. It may penetrate the soft tissue. It's probably not going to come out. If it does, it doesn't create a lot of tissue trauma. It's a through and through. The patient go home the same day from the ER. Or if it does hit a bone, it's like a crack in the bone or some simple fracture pattern. Then you have the shotgun where it's just a blast. It's blast. It's scattered. You have pellets. You've got all kinds of foreign material to deal with on top of the blast injury. Often leaves huge cones of cone of cavity of the destruction.
Mm-hmm.
Then you have the rifle injuries, which are probably the worst, I feel like, because there would be a lot of them. If you have one or two in your body, it's like not compatible with life.
Yeah.
But the rifle injuries, the high velocity, it would just create this. Even if you couldn't see it, even if the wound looked small, just when you open the tissue, it was just like somebody had dropped a grenade inside them and let it blown up. It was just
Yeah.
so destructive to the bone, the soft tissues. Always, if it was a handgun injury, usually if they have a nerve injury, it was minor, it was
Mm-hmm.
self-limited, it would go away. The rifle injuries, there was neurologic problems every time.
Yeah. Yeah. It's really interesting. They when we document these cases, like in the OR, they never wanted us to say, oh, well, the entrance wound was this and this was the exit wound, because the pathologists or the forensics people didn't want conflicting documentation, in the medical record or something like that. But essentially, you would, I remember, you see these little holes in the skin, just like a little punch out hole, perfectly circular. And then you just roll the extremity over to the other side. And then it's just like, boom, just a huge
Like
irregular
a big
hole.
starburst pattern on
Yeah.
the opposite side. And That's why, we have the trauma bay, the room 4, as we call it at university, where
Gosh, yeah, you're bringing back all sorts of. I
you,
forgot about room 4.
you do things
Yeah.
methodically. You roll the patient. You look you look every inch, because you
Hmm.
could miss bullet wounds. You could miss, big, these bullet wounds can seem small,
Yeah.
and you don't realize it until you take an X-ray of their body. It's like, oh, do you see a bullet wound in the chest, or up in, like, I remember there was one, like, in the hair or braids of someone, like right at the nape of their neck, and like you didn't even know they had like a bullet in the back of their skull.
I wonder, maybe that remind. Maybe we're talking. Maybe I'm thinking about the same patient here. I remember a guy. I want to say the person came behind him and shot him while he was sitting in the car, and the bullet struck him in the head, and it at low velocity, obviously, in the head at just like the perfect angle where it penetrated his skin, and then the bullet followed his skull all the way around, like it didn't have enough energy to re-exit, but it stayed underneath the skin and just followed along, like, to the front here or something like that. Some just crazy,
Yeah,
like the magic bullet, right?
yeah, yeah.
Yeah.
That was a crazy time. You're working 30 hours in a row. I don't know what's urban legend at this point and what I actually saw.
Right, exactly. I'm pretty sure that happened though. Yeah, because I remember, like, maybe I was like I was like on the like the trauma service, the
You
gen
start
surg
to
trauma.
wonder,
Yeah.
like, how does this make sense? And then a lot of times, you take an X-ray and you see a bunch of bullets, like there's no wounds. It's like,
Yeah.
well, this is like their second or third time.
Right.
And I kind of touch on that in the article, but the recidivism of these people coming back
Mm.
was crazy. And our, trauma attendings used to say, like, trauma is like a disease.
Mm-hmm.
It's like there's a lot of people who just somehow find themselves in harm's way, whether it's car accidents, falls, gunshots, like just constantly in the same setting.
Yeah, you bring up a good point. Going back to your article that you published back in 2016, that 3,600 number were new gunshot wounds, not people who had been shot before, because you excluded those people. Like, if they had been in the trauma registry previously, you excluded them from the study. So the 3,600 number is underestimating the number of people who came in for a gunshot wound.
Right.
Yeah.
I mean, I'm sure you see
Yeah.
in your practice, same thing with car accidents to a degree. It's like, it
It's
seems like the
what
same
leg did you
people
break again? Yeah.
get in car accidents. I fixed a
Yeah.
lady's rotator cuff after a car accident, and on her way home from surgery, she got in a car accident. I mean, it's just sometimes, I don't know if it's luck, I don't
Just
know what it
trouble finds
is,
some
or
people, I guess.
bad
You know what I mean?
drivers.
Yeah. Yeah. And then the other thing to point out is, for our city in New Orleans, 3,600 people at one hospital. And there's large hospitals scattered throughout the city. They're not all trauma centers, but, somebody gets shot down uptown, they're probably going to walk or be taken to Toro or somewhere closer by, Kenner, whatever. They're not all going to the trauma center at first. And so you see this 3,600 number, but the number is much higher, much, much higher, I'm sure.
Right. I mean, this is one city and it's one hospital in
Mm-hmm.
one metro area. I mean, we've taken call at all the hospitals around New Orleans. I mean, we got
A lot of
gunshots at all of them.
Yeah.
It may not get the crazy high intensity ones, but you still get gunshots at all these hospitals. So yeah,
Mm-hmm.
this number is way under calling the real toll.
Yeah. And just because you don't end up at the trauma center doesn't mean you don't have a debilitating wound. You get a single gunshot wound, like through the knee, the patient's stable, they're not bleeding to death. They could go to any ER, I guess, and most hospitals here have some ER ortho coverage, so they get washed out, splinted, and referred to Lord and Taylor Clinic.
Exactly.
Right, exactly. That definitely, but I asked you about, what are some of the worst cases that you've seen? You mentioned the rifle wounds are the worst. Can you recall, like, a particular case that stands out to you, like a particular patient or something you were involved with?
I remember a few. I know we were talking about that shoulder case, and that might be the same one as you, but I definitely remember.
The police officer?
Yeah,
Yeah.
like, unfortunately, police officers, they're always in their car, and it's some
Yes.
sort of ambush situation, so they're always kind of getting shot towards the left upper shoulder, just like truckers always get
It was his left upper shoulder.
melanoma on their left arms because that's what's exposed.
Yeah.
And so just the destruction of a powerful weapon that close range, and it just destroyed the shoulder.
Mm-hmm.
And like we were talking about before, like blunt force trauma, like scapula, the glenoid, it's not rarely seen broken. So we don't rarely
Right.
do exposures to it. So no one is an expert on that.
Mm-hmm.
So when you get these like high velocity injuries to areas that we don't usually operate on,
Mm-hmm.
I just remember because it was such a challenge. Like, what are we going to do?
Right. Yeah. So for the audience listening, so the point you're making is there's types of fracture patterns based off of typical injury mechanisms, fall, car wreck, or, forces across an extremity joint or whatever, and the bone will fail in maybe a fairly predictable pattern. And there's a lot of classifications that are based off of that, right?
Right.
And then but then if you have a high velocity projectile that hits your shoulder ball and socket joint, well, then all bets are off. Nothing falls within a reasonable predictable pattern for treatment.
Right.
That's what I
Like
think you're getting
basically
at.
all the plates and screws that are made, they're
Mm-hmm.
based on predictable blunt force trauma type patterns.
Yeah.
So all the equipment we have, all the articles that have been written, all the textbooks that have been written, they're based on these exposures to standard areas that usually get broken.
Mm-hmm.
Like the femoral neck is constantly broken because it's a weak point in the body as we get older. So there's lots of approaches. But when you talk about gunshot wounds, it's highly unpredictable. There's no studies, there's no books, there's no special plating for that. So I feel like everyone was like, it was like an art to figure out how to fix it.
Mm-hmm.
And there was no expert to call on or book to read to figure it out.
Yeah, just experience, having attendings who are used to dealing with this type of injury, and using, classic orthopedic internal fixation principles as best you could to stabilize the bone, reconstruct the joint, to try to ensure as much future function down the road. I think is, yeah.
Right. Other places they see a lot of the blunt force trauma. If you throw a
Mm-hmm.
bone at the wall 20 times, it's going to break in a very distinctive pattern. If you twist
Right.
a bone a certain way, it's going to break in a
Yeah.
very distinctive pattern. It's when you do a gunshots, all bets are off. So
Mm-hmm.
it's like, I don't know if that makes our education better or worse, that we had to kind of think outside the box and really be
Yeah.
creative. But it's definitely different compared to
Mm-hmm.
if you went to like, you know, Boston, and their blunt force trauma to penetrating trauma ratio is reversed of ours.
Yeah, that's a good point. It can, and I guess that was part of your, you mentioned part of your study is how does this affect orthopedic residency training, and it can get skewed, depending on the location you're in. You know what I mean? I guess that could be for, honestly, in sports medicine, you're sports trained. If you're West Coast or up in the mountains, you probably get different types of sports related injuries, like an AC joint separation where there's a lot of like biking, a lot of people biking. You probably see a ton of that. In New Orleans, we just happen to have a lot of gun violence.
Yeah.
And so we see a lot of gun violence trauma.
Well, yeah, I mean, it makes me think of a non-gunshot, but like gator bites. Like I think I've treated like 4 or 5 severe alligator injuries that were like horrific, like jaws and swamp water and like infections you've never heard of.
Mm-hmm.
Whatever part of the country you're in, or you're going to get these weird injuries that no one else gets.
Right. Yeah. Like, a great white shark attack in San Diego, or I don't
Right.
know.
Yes. Or big.
Louisiana, you get mangled by an alligator.
Yeah.
Right. Man, but, as you're telling me about some of those cases that stand out to you, I've got a few that I just, thinking about things. I remember early out in practice, maybe 1 or 2 years, this guy had his door kicked in. Or that's what the other thing is, you don't really know the story behind it. You kind of start hearing the story from the nurses and stuff, but the story for this guy was somebody kicked his door in and just started blasting. So he shows up in extremis, which I guess is the right way to say it, which means essentially he's on the cusp of dying. And he's shot in the belly, maybe chest, and 3 out of 4 extremities are just shot. And so you have to like super prioritize what you're doing at that point. So in this particular case, the trauma surgeons have his belly open, stopping the bleeding, doing what they do. Splint the left upper extremity, because you can splint an upper extremity, and then both his left and right femur were broken. And so to stabilize, and they were comminuted fractures too. And so I think that was the first time I've ever like X-fixed somebody really without fluoro for every shot. You know what I mean? Because you couldn't get fluoro in because the gen surge and the trauma surgeons were doing what they needed to do, and you had to like he couldn't just be sitting there with these floppy, unstable legs. And so fortunately he was thin, so you can palpate bony landmarks and just feel bicortical, with the and then you just put the X-Fix pins in, stabilize the femur. And so that was a pretty wild experience for me.
Well, it's pretty interesting. I mean, with ortho, you'd think we're like the last discipline to get involved in these major traumas because obviously we're not life-threatening. But, if you have 2 broken femurs, I mean, that's life-threatening. And if you don't stabilize them, they're flopping around. They could tear up other stuff. They're bleeding like crazy.
So what is the rule? I can't remember, but like the rule is like you can lose how many liters of blood in your thigh?
It was something absurd.
It's a lot. Yeah.
Yeah, I remember that was one of those orthopedic trivia questions that they used to ask us.
1, 2, 3 liters, maybe. I don't know.
Yeah,
a lot.
Yeah. And then same thing with people who have brain injuries, whether it's gunshot or blunt trauma. If the bone's flopping around, you're increasing your intracranial pressure because of the pain, because of the trauma. So it's like we had to get involved in a lot of these kind of horrific injuries that you would think, ortho will figure it out later if the patient does well.
Yeah, there's a statistic in your study. I'm trying to remember what the number was. I try to have some of this available because I thought the numbers were interesting. Oh, here it is. So 25. So out of all the gunshot wound trauma consultations, so ortho had about 25% of them. I think. Does that sound about right?
Exactly.
Okay. Yeah, and then I can't remember exactly how many, but a substantial number of those went on to the operating room. So. Yeah, ortho is certainly involved for sure with that. There's this other crazy case. You mentioned the shotgun blasts and how bad those are. Even birdshot. There's when you in the gun community world, there's this debate over what's a good what should you use for home defense, right? And everybody's like, oh, you need buckshot, right? Well. This guy came in. There's no way this was buckshot because all these little pellets, and he got shot pretty close. I would imagine in the home range, shot in the leg, and he had, dozens of these pellet wounds all over his leg, and his tibia was broken from the knee joint all the way down to the ankle joint, and all those pellets, a lot of those pellets had enough energy to penetrate the skin, muscle, and the side of the bone where the gunshot wound occurred, but not enough energy to go out. And so they had hit the bone on the far side, and they just got stuck all in the bone. So he had these just dozens of pellets all the way down from his knee joint all the way down his leg. Just, what do you do with that? You can't go. It's impossible to go through there, and like if any piece of his pants, foreign material, gets in that, there's no way you can get that out of the guy's leg. To clean it.
It's just like with the shotgun things and the rifle, it's just the infection risk. It's like, and then how much do you debride? It's like, you got to leave something.
Yeah.
But
so like the C's. So you remember the C's? You remember those?
I do not.
I don't want to quiz you. So like color, like the color, like, so the muscle. So the C's for the audience. When you have a bad gunshot wound, the muscle is so disrupted that you have no idea if the muscle's viable or not. Like the muscle could die at any time, and if the muscle's dead or non-viable, it's a nidus for infection. And so you're looking for like, what is the color?
Color, the contraction, if you got it with the bovie.
Yeah, meaning is it, bovie and stuff like that. And there's some other things, I think, but you just know at this point. You kind of look and you sort of know.
When you're in residency, everything's a quiz, everything's an acronym.
So what are the 3 C's?
Yeah. And then once you get out, you're like, all right, this just makes sense. This is just what we do.
Yeah. So that I do want to, let's go back a little bit to, dealing with that initial consult, from like the initial consultation through the hospital stay. We're kind of bouncing in and out of that conversation, but okay. Dr. Russo, here's your page. We've got this, unfortunately, 20-something-year-old male, usually a male, multiple gunshot wounds. Go. What's going through that?
It's different than what we want to do as ortho. Is we want to like say, all right, the bone's broken, all right, let's go fix it. There's so much more going on from the psychosocial aspects of it. There's, if somebody got shot, there's obviously police involved. There's what happened. Well, a lot of times like you don't really care what happened. Like you You broke your ankle. I don't care if you fell off a bar stool or you were drunk
Right.
or your high heel slipped on the curb.
Hmm.
You don't really care about the story so much. But with the gunshot wounds, I mean, the story is driving what's going on with that patient. And on
Hmm.
top of that, you got the general surgery aspect of things, the life-threatening aspect. So immediately it's a lot more than just the bone's broke, you need to
Hmm.
fix it. So that's, the first thing. It was a lot more complex than just your standard consult.
Hmm.
And then you're working with your partners to go through the system. Do you get to the OR right then and there? Can it wait till tomorrow morning?
Hmm.
These things.
What are some things that would prompt you to go to the OR right then?
So I think we were used to be like the gunshots were like treated like an open fracture kind of when we started, and then
Hmm.
more studies came out where it's like, all right, low velocity gunshot wound really doesn't need to be treated like this open fracture emergency. So I think the big thing is the low velocity means you can probably wait
Hmm.
until the next day or so.
Hmm.
The other thing is the high energies. Unfortunately, they were always you had to go to the OR then and there.
Yeah.
There were vascular compromise, compartment syndromes, soft tissue issues.
Hmm.
I mean, just pure exposed bone.
Yeah. What's a compartment syndrome? I know you know, but some
Yeah.
people might
So
not.
yeah, the compartment syndrome. Usually, when the bullet wound was a little smaller and it goes in and creates all this swelling,
Hmm.
you've got all your muscles in a compartment, like that thin layer on the back of ribs that you peel off. Like that's keeping all those muscles in that compartment. And if it swells too much inside that compartment, it then cuts off the blood supply,
Hmm.
which can then make the muscle die, which will then destroy your kidneys. So it is a true
It's
medical
like the pressure
emergency.
increases so much, like you can't get good blood flow
Right.
to
And
the
there's
ear,
some
right?
some
Yeah.
early signs, obviously the pain, the stiffness of it,
Hmm.
your nerves stop working, your vascular stops working. That's kind of towards the end of it. Your labs will show that there's muscle death. But those are true emergencies, so you can't wait till the next morning.
Hmm.
So yeah, like you said, first thing when you see the patient is, can this wait? You
Hmm.
have to triage, just like
Yeah.
everything else in life. You have to triage, because everybody can't have the OR. You can't just say, I'm the king of the hospital. I need the OR right
Right.
now. So you need to be a good steward of your resources. And so you got to decide, is this emergent or is it not?
Right. Exactly. Um, and so, okay, so if you got to go in the middle of the night, upper extremity, usually maybe you wash it out, maybe splint it, maybe. I guess you might. Often you're not like definitively fixing things necessarily, though, right?
Right, right.
Or
Most of the
maybe.
time, you're going to X fix it, unless it's more low energy. I feel like the high
Hmm.
energy wounds, it was always so shattered. You need a plan. You need
Yeah.
special implants. You
Right.
need neurosurgery involved or vascular involved. You need plastics involved.
Hmm.
So all that can't happen in that short
Yeah.
amount of time.
Yeah, sorry. So describe external fixation.
Sure. So
Yeah.
so external fixation looks like an erector set on the outside of the skin.
Right. As a
You've
kid.
got
Yeah.
some silver pins sticking out of your skin, and there's bars that are holding those pins together. Well, those pins are in your bone, so it's a way to splint it, but very sturdy, to allow us to kind of figure out the next treatment plan. It's a temporizing measure. It's not meant to be a long time
Hmm.
measure, but that we can live to fight another day basically with external fixation.
Yeah, I like the way you describe that. The other way, live to fight another day. I tell patients we got to get things under control. That's sort of not necessarily a gunshot wound, but it could be any like really bad open wound where there's a lot of like mangled tissue, really bad swelling. The fracture pattern is so complex. You just can't do it in the middle of the night. You got to get your team ready, all that type of stuff. External fixation, get everything sort of like lined up, stable, under control, and then it gives you time to figure out definitively what our options are, essentially.
Right. And,
Yeah.
all of our specialties are different. We're the same
Hmm.
subspecialty, and
Yeah.
we do different things. So
Yeah.
you may be at a hospital where that guy is more of a sports guy and he's
Yeah.
hasn't done a both bone forearm, let alone one that's missing large chunks of bone.
Hmm.
So the X-Fix allows you to get maybe to the right subspecialist
Hmm.
so you can get the best possible, chance
Yeah.
at recovery.
Also, the X fix lets you sort of manage the wound too.
Hmm.
If um, if you so you've got a couple pins in the bone, the pin goes through the skin into the bone, and then but you have like almost circumferential access to the extremity, and so you can manipulate the extremity for repeat washout. So as you might be going back to the OR over and over again to clean the wound, see if the muscle's dead or alive or whatever. And then and it gives you that easy access to kind of manage that situation too, you
Yeah.
know.
You know, it's interesting that like the number one code at the end of our 5 years of residency for
Oh,
me
was an exfix? Oh, debridement.
was a wound vac.
Oh, was it really? Yeah, I think that was the same for mine. They're just so common, like, but
Yeah.
you do it multiple times
Right. And most
in one
people
patient.
aren't going to know what a wound vac is, and hopefully they never have to know. But
Yeah.
basically, it's, putting a bandage on this big open wound,
Hmm.
as you would think, and it's going to get stuck to the tissue. It's not really sterile. This
Yeah.
wound vac really suctions everything, keeps it nice and tight, airtight, doesn't allow the bacteria to get as much as possible.
Hmm.
And that really allowed us to do much better jobs with soft tissue compared to, say, 10, 20 years prior.
Yeah, very good point. And the nurses love it too because the
Yeah.
wounds are clean and
You're not
dry.
constantly just bleeding,
Yes.
oozing. Yeah, everything's self-contained.
I've got a pretty low threshold to wound vac stuff. Just it's not often the wrong answer. You know
Right.
what I
You,
mean?
you can't do a lot bad with a wound vac.
Yeah.
So it's always the right call. And, it allows you to get other opinions. It allows you to take
Hmm.
a break, figure it out. I mean, that's why I think we had so many applications of it.
Yeah. Yeah, that's funny you mentioned that. I think I noticed that as well. I was like, wow, I've got the debridement code down, multiple debridements. Oh, so let me give you another patient of mine that I've dealt with. Back to that human toll we talked about. This guy was in his 50s and he was shot in the spine when he was like in his 20s. So he had been a paraplegic for 30 years. And with being a paraplegic comes, as you well know, all sorts of problems, right? Urinary tract infections, bed sores, all sorts of things. You can't move, so you can't shift your weight. And if you're sitting in one spot for a long time, the skin necrosis, and then you can get a full thickness sore that goes all the way down to the bone. Well, this guy had that on his hip, and he had a big sore and had this infection that went all the way down to his pelvis. I think I washed him out because I love our plastic surgeons, but they didn't want to take his case. So I think I washed him out about 15 times. I kid you not, until he granulated from secondary intention from all the way down to like around his acetabulum all the way to his skin. I changed 15 times.
That's amazing.
I was like, what am I supposed to do with this? I'm not a plastic surgeon.
Right.
I take trauma call. I can handle trauma stuff, temporize it, and get it to our ortho trauma surgeons. So I washed them because but
It's amazing.
I remember that.
This is going to go on a tangent, but it's amazing
Yeah,
how
that's okay.
non-medical people don't know what plastic surgeons start out doing in training. Like you
Yeah,
think
right,
plastic
yeah,
surgeon, you
right,
think
yeah.
TV, boobs, faces, Brazilian butt lifts. Like plastic surgeons, as I remember them, like doing these intricate flaps, moving muscles over when we can't get any coverage. I mean, they did some intricate, like 8 to 12-hour surgeries, but a lot of it, that's, compared to doing some of the sexy stuff, that's not always exciting. So you don't have that many plastic
Right.
surgeons who want to stay in that field and do that kind of work, but it's like God's work.
It really is, and yeah, dealing with those types of wounds and having a plastic surgeon available who is eager to help is just incredibly helpful. I remember dealing with a few plastic surgeons in residency, and I mean, thank goodness for them to. So yeah, so here's an example. Big wound. So think down by your shin bone, right? So audience, shin bone. There's not a lot of. You have skin, and literally on your shin, there's your bone, right? There's nothing there. So you have a horrible wound down there. By the way, I just had 3 months ago. I had I think he was a teenager, or 21, young 20s who. I think it was high velocity through distal tibia. Terrible place to get shot. Everywhere is terrible to get shot, but there's no muscle or anything that you can mobilize to cover the bone. You know what I mean? And so having the plastic surgeons available to reroute the muscle to cover that. And you have to do that within a series, ideally within a certain period of time, or like your infection rates go up and things like that. If I recall.
Yeah, I mean it's frustrating. We can make the bone look beautiful, like come up with some
Right, yeah.
magnificent repair that like you pat yourself on the back, but if you're just staring at the bone's gonna get infected and it's gonna die. And you're gonna end up with an amputation. So not having those flaps is, it's crucial to have them. And I think the layperson doesn't even know what a flap is, and hopefully doesn't have to. I think some
Right.
of like the like the Tiger Woods injuries, and then the what's his face, the San Francisco quarterback, like seeing those on like the NFL, people are like, what is that big bulky tissue on his leg? I think it showed people like what a flap really is.
Yeah, yeah, exactly, exactly. You mentioned like infections and stuff. That's one other thing I remember about these gunshot wounds is that the chronic infections, like they develop an infection from the initial injury. You do everything right. You wash them out a million times. You clean, 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 clean. They get the antibiotics right away. They get the most powerful antibiotics that you can give them to keep the and there's just no way to keep things from getting infected, and they get like a chronic osteomyelitis, a chronic infection of the bone. It just like drains for years.
Yeah, we were talking about the one case you had, and I had another, like where the bullet goes through the bone and it like it just kills whatever was in its pathway. You can almost see like a little circle, like where the bullet went through.
Yeah.
The bone never regrows because there's so much bone death.
Yeah.
And the bullet is hot when it's going through your leg or your arm. It just melts the tissue. And so you have all this like food for bacteria, all this melted muscle, skin, and fat.
Yeah.
And God knows if it went through your genes, you got pieces of genes in your skin somewhere where you can't reach. So it's the infections were tough, and there was no real good way to treat them. I know we tried oral antibiotics. We tried, debriding around the little wound holes, but nothing ever was perfect.
Yeah. Yeah. Really, really horrible type of injuries. Well, look, man, I don't know if you have anything else to add to this, but sitting down with you, it's been really great to catch up, and unfortunately reminiscing over a really bad problem that our city has. But,
Yeah, I mean, it's we're nothing like the military, but it's kind of like old war stories, even though it's sad, it's kind of bonding. It's like a mature way to deal with psychological trauma that I'm sure we all have, is kind of talking about it and trying to make some sense out of it.
Yeah, when you go through challenging times in your life with other people, I think the natural thing to do is bond with them, and then you can share you go back and share those stories. Like, I when's the last time I've spoken to you face to face?
Has to be 9 years.
Has to be 9 years, but it's still pretty easy to talk to you.
Yeah.
You know what I mean? It's almost like it's not a whole lot of time really seems to have passed, so to speak.
Yeah, it's funny. I'm sure we look older to other people, but like you look the same. I feel like
You
we
look
could
exactly the
just be
same.
running around in our coats, our scraggly coats, like
Yeah.
20 hours in the hospital and just
Right.
like fighting battles together.
Yeah, I hear you, man. Fighting battles together. Well, look, really appreciate you coming on the show. This was a daunting topic to hit. Just trying to get. There's just so much to talk about, and I feel like we could do like another hour or something like that. But look, I really appreciate you coming on and sharing everything with us.
Awesome. Thank you.